Welcome back, everybody. It's been a short hiatus, but thank you for joining us again. Again, my name is Dr. Cow. I'm today joined by Dr. Angela Fisher. She's a practicing OB/GYN physician or obstetrician gynecologist for short. Uh, and so she'll be talking to us if OB/GYN is a good fit for you guys. So welcome, Dr. Fisher.
Thank you.
All right. So we'll start off with a little bit about your background, and then go into like the general detail of what does a OB/GYN physician do.
Sure. After completing residency, I did 3 years in a hospital-owned practice. And then after that, transitioned into a laborist model, meaning that I worked just in the hospital on the labor and delivery floor, taking care of women and their fetuses while they're in the hospital.
Okay. All right. And then can you give us a brief description of like what all does OB/GYN entail? It's not all about delivering babies, correct?
Right. Delivering babies is probably the minority of your job if you're doing general OBGYN. So if you do general OBGYN, most of your day is going to be spent in your office seeing patients. That might be pregnant ladies, it might be birth control consults, pelvic pain, abnormal bleeding are some of the big ones that we get. And then of course, well woman exams as well. And then everybody's different on what their sort of operating room schedule looks like. I did 1 day a week in the operating room. So you might do hysterectomies or hysteroscopies, looking inside the uterus with a camera, or other minor procedures like that, as well as that's when I did scheduled C-sections, I should say. And then on top of that, delivering babies. Again, that's one of the things that sort of varies by practice. For my group, we were in the office even when we were covering labor and delivery because it was right next door. So you would just sort of leave during the day to go over to the hospital to deliver a baby if needed. Call's another one that changes, but babies come when babies come. So you get to go in and deliver them, as well as usually you'll cover the emergency room. So things like ectopic pregnancies or heavy bleeding, miscarriages that come in that way, you'll get calls about that to come in.
Okay. All right. Thank you for that. And you discussed regarding a training, residency. How long is a typical training, and then are there fellowships involved after that?
Yes. So OB/GYN residency is 4 years, and then there's several fellowships off of that. So the ACGME accredited fellowships are reproductive endocrinology and infertility. So hormonal imbalances, and particularly the infertility aspect. There's maternal fetal medicine, which is high risk pregnancies. There is female pelvic medicine and reconstructive surgery, more commonly known as Urogyn. And then GYN oncology is the other one. Those are the ACGME accredited ones. They are each 3 years. There are other fellowships in peds and adolescent and minimally invasive surgery that are 1 to 2 years, but they aren't sort of recognized by the board yet.
Okay, so with fellowship could be potentially 7 years.
Yes, potentially 7 years.
All right. That's essentially a surgeon's life.
Yes, if you did a general surgery residency, you'd be looking at 5 plus any additional training you did to specialize that. So it's pretty standard for surgery.
Okay. All right. So thinking back to the medical school days when I was undecided, I assume most people were pretty undecided. What made you pick OB/GYN as your specialty?
And so when I started med school, I knew that I wanted to do a something that involved procedures. So I was sort of leaning surgical. I thought maybe ER, doing some procedures there. But then once I started doing my rotations, I realized that I really liked the continuity, or rather I missed the continuity on the rotations where we didn't have that as much.
Hmm.
So then that sort of narrows things down if you want to do procedures and have continuity, because a lot of surgical specialties don't. You operate and then you may or may not see them again.
Hmm.
I tried really hard in medical school to talk myself out of OBGYN, but there just wasn't anything else that sort of fit what I wanted to do. Because if you do general OBGYN for years, you'll see women from their teenage years, childbearing years, all the way through menopause, if your ages correlate.
Hmm.
And so that was something that was really attractive to me, along with every day is different. I might be in the office, I might be in the operating room, I might be delivering babies. And so that variety was important to me as well.
Okay. So you considered ER. What other
Mhm.
specialties did you consider?
General surgery, but not like I didn't think too hard about that one. ER was the main one. I looked a little bit at physical medicine and rehab
Hmm.
for that. But like I said, I just um, couldn't talk myself out of OBGYN as hard as I tried.
Okay. All right. So what's the most exciting aspect of the being an OB-GYN physician?
So somebody told me OB-GYN is like 95% sitting around when you're on the OB floor, and then like 5% just sheer adrenaline.
Yeah.
So whether it's delivering babies or going to the OR and having to make those decisions, you always have to be ready. The happiest moments are obviously your vaginal deliveries, especially if it's somebody you've been taking care of for a while.
Mhm.
Getting to share that, one of the biggest moments of their life with them is obviously very exciting. But in a less happy way, a lot of what happens on the OB floor, at least the part that's managed by physicians, is at least adrenaline producing, exciting, if not necessarily happy, exciting.
Yeah. Yeah. And then you discuss a little bit about the, I guess when you were making decisions about the bad part about OB-GYN, can you process through that
Yeah, so
part?
my main hang up with OP-GYN was the schedule.
Okay.
And I would say that's probably um, a lot of people's hang up. Even if you don't recognize it in med school, it's something to consider afterwards. When I was in practice, initially my call schedule, I was actually on call from home, but it was every other day. So I'm 2 week or 1 week in a month. So I worked 11 or 12 nights I was on call,
Okay.
which for me was not sustainable in the long run. But that was the part that concerned me. We did a rotation in our med school called community health, where we literally lived in the hospital because that's where they could board us.
Mm.
So and we were right off the labor and delivery unit. So I got to see like firsthand the OB doctors going in to deliver babies, because they would call me at like all hours of the night and all the time.
Mhm.
And so that was, yeah, at least I went into it with realistic expectations, but that was the main thing that had me concerned, was that just that schedule and being able to attain a work-life balance.
Understood. Understood. And how has that fear came to maturation with your practice now, and how does it, I mean, how do you feel like your colleagues have dealt with that?
Yeah, so for me, I ended up just going to be a laborist. So much like an ER doctor, when I'm at work, I'm at work. And when I'm at
Hmm.
home, I'm at home. I'm no longer on call. So I work 24-hour shifts, and then I go home and I don't go back to the hospital until my next shift. There is a happy medium between every other day call and leaving the office like I did, but it's going to depend on usually the size of your practice, but also the setup of your practice. So where I went to residency, I would say that most of my attendings were on call about every fifth night.
Okay.
So one night a week, 1 weekend a month on average, which is definitely more sustainable than what I was doing. But it does still start to wear on you. And so it can be a tricky specialty to find that balance in.
Okay. Okay. Thank you for that. Yeah, I've met few working the ER. I've in contact with a few OB-GYN obviously for
Yeah.
consulting, but they tell me they work your job with which is like almost like a hospitalist kind of
Right.
position, which I've never really heard of in med school. That was
Yes, yeah,
possible.
I had no idea that it existed. It's a growing field. There
Mm.
are OB/GYN hospitalist fellowships. It's not yet a recognized thing. There's only maybe half a dozen in the country, but I would not be surprised if 10, 15 years from now, it's almost required to get the job that I have to have done that extra year of training.
Oh, wow. That's impressive. You don't have to do the training in
Yeah, I
the
won't.
future.
I'll get grandfathered in if I stick with it. So.
That's fantastic that there's, you mean, positions to make it work with your life as well.
Yeah, there have been several studies that show better outcomes because we are there and that's what we're focused on.
Hmm.
There are some private practices near where I was before where at 5 p.m. a hospitalist takes over and the hospitalist covers on the weekend.
Mm.
So if you really want to do it all and try and find a balance, that would be an option. That's probably a model that will grow some as well, where if the baby comes between 8 and 5, then you're there to deliver them. But from 5 to 7-ish,
Mhm.
there's a laborist there to take care of it.
Okay. All right. Thank you for that. And you said your current schedule, you're on call 24 hours.
Yes.
How often are you doing
I
this?
do 6 a month. The
Okay.
national
Wow.
average for a hospitalist is about 7 a month.
Wow. That's a that's a lot of free days.
It is. It's a lot of free days. Yes.
That's pretty awesome.
Yeah.
Congrats for getting a really quick schedule.
Yes. Yeah.
Uh,
It's been great.
we talked about the scheduling, and we talked about the great aspect. Are there any frustrating aspects being an OB/GYN physicians that you think medical students should know?
Yeah, I think I think there's a lot of frustration sort of built into the daily office grind. We're not technically, well, by some viewpoints, we are primary care providers for the women's health of things.
Hmm.
But some of that's just it's become built into our medical system. The the paperwork, the refill requests, the clicks here and there that don't necessarily impact patient care.
Hmm.
Those were a big frustration. Personally, I did not like being torn between the office and labor and delivery or the OR. So when I had patients waiting in the office, but I felt like I needed to be on labor and delivery, that was really hard for me.
Hmm.
And so that was something that I had a hard time balancing. There are groups that balance, that if you're in the hospital, you're in the hospital. If you're in the office, you're in the office.
Hmm.
Those are typically bigger groups that are busier in the hospital. So there's a way to avoid it, but the way my practice was set up, it wasn't possible. And so that was a big source of frustration for me, was feeling like I needed to be in two places at once.
Gotcha, gotcha. And how does one pick like a setting that they want to practice in? You pick to be in a more private practice. What's the, I mean, private versus academic?
Mhm. So it's what you want. I didn't necessarily foresee myself wanting to teach. I wanted to go into practice and kind of be on my own and get a feel for things on my own.
Hmm.
Learn the way that I do things and get comfortable doing it. Once I got there, I realized that I really missed that teaching aspect that I'd had with the med students and the younger residents in residency.
Yeah.
And so now I've swung back to where I'm back in a teaching hospital. But some people, they don't miss that part and they enjoy what they're doing without that aspect. And so they'll choose to stay in private practice. Um, the setup for the academic practice varies based on where you are.
Mhm.
Where I am now, the academic docs that are in the office, they don't come to the hospital.
Okay.
So they just see patients in the office and supervise the residents there. And then we take care of them when they come to the hospital. So we have that kind of division of labor.
Okay.
Where I trained in other places, they may take call as well for their own group. So it kind of depends on, there's different variations everywhere.
Okay. Awesome. Thank you. And then one of my favorite questions to ask is, what are the myths about OB/GYN that you think are unfair and untrue?
Yes. I actually texted a couple of my friends when I saw that on your list of questions. And I was like,
Yeah.
we're gonna have to, I was like, I don't know that I have any that I think are untrue.
Hmm.
We've talked a lot about the schedule, which I think is a big one that concerns people. It was certainly my big concern. But I think the other one that it's fair to know about is a lot of people think OB/GYN and they think either, oh, you're delivering babies all day,
Hmm.
or oh, you're doing pap smears all day, or it's a combination of pap smears and babies. Um, but it's honestly a lot more than that. There's, you're there when they have their miscarriages or their stillbirth. you may be diagnosing their cancer for the first time, or helping them through when they find a lump in their breast. And so there are very tough conversations that you have to be prepared to have. It's not all the happy, here's your baby. Along with that goes the worst outcomes, the moments of real fear when you tell them they're going to have a 26-weeker, and well, what does that mean?
Hmm.
And so you have to prepare for that. And that's not something we tend to not let students in on, that side, because it's such a difficult moment for the patients that we don't necessarily want to bring in extra people. And so you sort of get shielded from that. But it is certainly not a big part, but it's an emotionally wearing part of the job.
Hmm. Yeah, yeah, I can totally relate because we'll see some of those in the ER, and it's
Right.
delivering the sad news is.
Yeah.
Yeah. Okay. All right. Thank you for that. And let me see. What do you think is the uh, best qualities to have as a student to be a successful OB/GYN physician?
Yeah. So you have to be comfortable, maybe not knowing everything, and
Mhm.
you have to be comfortable quickly changing gears. So you may be admitting this routine patient, but then all of a sudden there's some emergency that happens. So you have to be able to switch gears quickly, and switch your brain from GYN to OB, and back and forth. And you have to be comfortable with that. Um, and comfortable, if you're going to do general OB/GYN, it helps to be comfortable in multiple places as well. So
Yeah.
like
Yeah.
I said, I didn't cope well with being torn between two different places. There's a certain amount of flexibility that it requires. I was okay, I could go if I was in the hospital and needed to see a GYN patient or an OB patient, that was fine because I was there. But once I was being torn between two different locations, that was where where my
Yeah.
disconnect was. So I think that's really important. Um, and then obviously, you want to practice your surgical skills. We're a surgical specialty.
Hmm.
That, and then just, staying curious, because things are always changing. There's a big focus right now on maternal mortality.
Yeah.
And so we're really starting to streamline some of our care, and look at sort of best practices and the best way of doing things.
Okay. All right. Thank you for that. And what do you think is the outlook for OB/GYN in 10 to 20 years? Any changes you see coming?
Yeah, well, I mean, first off, we're facing a huge OB/GYN shortage, just in the years to come, especially in rural areas. There's more and more rural areas that are closing their OB/GYN practices. I was
Mm.
in a rural area before. That's part of the reason my schedule was as rough as it was. But
Mm.
we were the only hospital in any direction for an hour that delivered babies. We were actually the
Oh,
only OB/GYN practice for an hour that delivered babies. And like, if you went west of us, there was a nurse practitioner that saw pregnant ladies, but she didn't deliver. So it was
mm.
an additional hour beyond her to get to another hospital. So, especially in the rural areas, we're going to need more practitioners. But I think you're going to see us getting more specialized. I think you're going to see a shift towards better work-life balance. I think the newer generation of doctors isn't as willing to be on call every 2 nights, or to I think you're going to find a better balance. And as we specialize more, you'll get that. You'll have your GYN surgeons who do surgery. You'll have your OB hospitalists who manage patients in labor and in the hospital. And then you'll have your office specialists. And I think that those together will probably improve outcomes, but they'll definitely improve lifestyle for the doctors and make it a more manageable experience.
Awesome. Thank you for that. And you discussed regarding working with nurse practitioners and other
Mhm.
mid-levels. Is that typical in the field, working with mid-levels and midwives, I guess, would
Yes, and
consider
midwives.
with that? Uh,
Yes, so in my practice, we had a nurse practitioner that saw patients with us, or saw her own patients, and helped sort of build our practice, because she could see patients, but she didn't deliver them. So from a is from a billing standpoint, as you get on down the road,
mhm.
it helps to have that flow of patients in, but that then you deliver, because that's how you get paid, is by delivering the baby.
Mhm.
So that helps. So you'll see nurse practitioners there, and you'll see physician assistants in the office.
Mm.
Sometimes you'll also see them assisting in the operating room.
Mhm.
Some of the bigger practices will have a dedicated physician's assistant that do their procedures with them. And then midwives are the big ones
Mhm.
um, that we work with. probably the most nationwide because they can deliver babies.
Mhm.
And so that's a great way as well for your low risk patients. It's a more tends to be a more like hands-on and holistic because instead of addressing the hypertension, the diabetes, the whatever else is going on, they can
Mhm.
really focus on optimizing the labor progress, some of the more hands-on maneuvers to get babies to descend and things like that.
Awesome.
So they can be really helpful both in the office and on labor and delivery, sort of extend our reach.
Okay, awesome. And do you feel like their responsibilities will change over the years, or it's going to be same but similar?
I think it's probably naive to say it'll be similar in general.
Mhm.
That level of practitioner is um, increasing their responsibilities. Certainly, rurally, nurse midwives I think might see more of a spread there. But as our pregnant population ages, just in general, women are having babies later.
Yeah.
We tend to have a higher risk population of pregnant ladies than we did 10, 15, 20 years ago.
Mm.
And so that, they tend to risk out of midwifery care and end up having to be seen by an OB-GYN, or a larger portion of them do than did 15, 20 years ago.
Okay. All right. And with your estimation that there'll be shortages, is a safe assumption that the job market in 5 to 10 years is for the current students watching it, it'll be pretty good if they go in OB-GYN?
Yeah, I'd say the job market would be pretty good. When I was applying initially, there was no shortage of jobs to apply for. When I
Mm.
applied for my laborist position, I knew I wanted to be in Chattanooga, so that sort of narrowed things down even further. But um, I definitely think there'll be plenty of positions. You may, like I said, might have to be a little flexible on where you want to go because certain areas will get saturated.
Mm.
But if you're more flexible on where you want to be, then you could certainly make it work.
Yeah, I didn't know what the situation was. Some specialties, like the
Mm.
metropolitan area, is super saturated, and then you have to get jobs well, like maybe 30, 40 minutes away from the metropolitan area. I didn't know that.
Right, and you definitely see that in some areas with OB-GYN. The places that are the most popular to live tend to fill up with OB-GYNs, but then as you move out from that area is where you'll see the openings.
Okay, all right. Thank you for that. Let me see. Uh, all right. So, what other career opportunities can you do besides doing the clinical aspect as an OB-GYN physician?
Yeah, so there's obviously academics, you could go into teaching.
Hmm.
Simulation is becoming a bigger avenue for OB-GYNs because so many of our situations are relatively rare.
Mm.
So whether it's eclampsia or shoulder dystocia, postpartum hemorrhage, we do a lot of simulation with those so that when they happen, we're prepared for them. So if you're somebody who's into that side of things, then that would be an avenue for you to go to. Um, I think most of us are clinical in some way, but
Hmm.
you can kind of tailor it to be just office, mostly surgery, that type of thing, depending on what you're looking for.
Okay, awesome. And then for students who wants to know if OB-GYN is a good specialty for them, do you have any helpful resources for them to pursue further?
Yeah, I would start on the ACOG website. It's just
Okay.
acog.org. There's a section there for medical students. Membership is free for medical students, or at least it
Mhm.
used to be. I think it still is. Um, so that you can kind of see they have like the residency programs and the process there that you can go through. And that'll be a jumping off point for you.
Okay, awesome. And then my last questions is essentially if you have any big tips for students wanting to go into OB-GYN or just pursue any medical career in
Mhm.
general. And then lastly, I just wanted to thank you for your time. You have a family, a loving husband, and whatnot. So I appreciate your time and knowledge in discussing these issues with students. And so that way they get to know, the real life aspect of being out there practicing.
Yeah, absolutely. I will say when you're on your rotations, if you want to do OB-GYN, pay attention.
Mhm.
Okay. Even if you don't want to do whatever it is, this crazy thing happens when women get pregnant. Nobody else wants to be their primary doctor when they're in the hospital.
Mm.
As soon as they're pregnant, they're OB's deal. And so I guess that's fair. They are pregnant, but regardless of what they're being admitted for, I tend to be their attending. So
Hmm.
make sure so get comfortable managing, whether it's an asthma exacerbation or DKA or whatever, brush up on those now, because you're not going to see a lot of them in residency and so forth. So make sure that you're learning from sort of what the standard of care is now, so that
Hmm.
moving forward, you're more comfortable managing those.
Okay. All right. And if there's anything else you'd like to add that I missed, please feel free to use this time.
Yeah, no, I think we've covered it all.
Okay. I appreciate Dr. Angela Fisher, your time, and have a great day.
All right, thanks.
All right. Bye.